Hi, my name is Josh Kass, and I'm a pediatric cardiology fellow here at UT Southwestern Medical Center and Children's Medical Center Dallas. Thank you very much for inviting me to present my research project, which is titled Blood Product Transfusion in Pediatric Cardiac Surgery, Exploring the Effects of a Standard of Care Change. I would like to acknowledge and express my appreciation to my mentors on this project, Dr. Luis Zabala and Dr. Susie Hupp. Cardiopulmonary bypass, or CPB, has made modern congenital heart surgery possible, and with advances in technology and techniques, increasingly difficult surgeries are being performed on increasingly smaller patients. However, CPB induces a number of sequelae that can affect patient care, and which often necessitate the intraoperative and postoperative transfusion of blood products. Blood products frequently transfused to cardiac surgery patients include red blood cells, platelets, plasma, cryoprecipitate, and activated factor VII. Although transfusion may be required to maintain hemodynamic stability and in certain cases may even be life-saving, it is not without risk. Transfusion has been associated with an increased incidence of postoperative pulmonary complications, prolonged mechanical ventilation, hospital-acquired infections, acute kidney injury and other end organ dysfunction, and prolonged length of hospitalization. There are several indications for intraoperative transfusion. These include developmental factors such as the patient's weight, corrected gestational age, and maturity of the hemostatic system. There are physiologic considerations, like the cardiac anatomy and morphologic diagnosis, the degree of cyanosis and/or intracardiac mixing, and the balance between systemic and pulmonary vascular resistance. Finally, indications from the CPB run in surgery include hemodilution, bypass-induced hemostatic alterations, and the duration and complexity of the surgery. Though clinical practice guidelines exist regarding intraoperative transfusion to patients on CPB, they are based on adult data and are not necessarily applicable to the pediatric population. Therefore, when it comes to pediatric cardiac surgery patients, intraoperative transfusion practices vary widely between providers, even within the same institution. Previous studies have evaluated many pre-, intra-, and post-operative blood management strategies. However, pediatric literature on blood management and transfusion practices is mainly observational, and high-grade evidence is lacking. Therefore, more pediatric-specific research to determine optimal blood management is necessary. At Children's Medical Center, the decision to transfuse intraoperatively used to be empiric and was largely driven by practice dogma. Transfusion parameters varied widely among surgeons, and in many cases, blood products were transfused without any laboratory evidence supporting an alteration in hemostasis. Instead, transfusions were largely based on patient age, weight, diagnosis, and surgical field oozing. However, due to changes in surgical leadership, an algorithmic approach to intraoperative transfusion was established beginning in January 2017. The algorithm is based on recently published literature. As the algorithm demonstrates, intraoperative transfusion is triggered based on the correlation of laboratory evidence of deranged hemostasis and the presence of clinical bleeding. This standard of care change creates a unique opportunity for analysis of patient outcomes related to the different approaches to intraoperative and, by extension, postoperative transfusion within our institution. These data may help identify an effective transfusion strategy to maximize patient safety while minimizing the risk of morbidity and mortality. Therefore, the primary aim of our study is to evaluate the incidence and characteristics of post-op complications, as well as the frequency and characteristics of intraoperative and postoperative transfusion requirements in pediatric patients undergoing cardiac surgery with CPB before and after the standard of care change in intraoperative transfusion practices. The hypothesis is that intraoperative transfusion practices that are systematic and evidence-based are associated with a lower incidence of postoperative complications and with a decreased requirement for postoperative transfusion compared to empiric intraoperative transfusion practices. This study is a retrospective analysis of all cardiopulmonary bypass cases performed at Children's Medical Center during 2016 and 2017. There was a total of 623 cardiac procedures performed with CPB over this time period. 303 of those cases were performed in 2016 and were subject to the old empiric transfusion practices, and the other 320 cases were performed in 2017, after the standard of care change to the algorithmic approach. Data will be obtained from the Institutional Cardiac Surgery Database and from the electronic medical record. This study will include all patients 18 years of age and under who underwent a cardiac surgical procedure with CPB between January 1, 2016 and December 31, 2017. Patients greater than or equal to 18 years and 1 day of age at the time of surgery, patients without clear documentation of blood product transfusion data, and patients with a known bleeding disorder will be excluded from this study. Pre-op data will include demographics, the patient's cardiac anatomy and urgency of the procedure, signs of organ dysfunction and shock, cardiorespiratory support details, transfusion and relevant medications, the primary surgeon, the ROX-1 score, and the STS-EACTS mortality category. Intraoperative data will include the type, timing, and characteristics of transfusions, the age of the transfused blood products, details of the surgical procedure, and laboratory data relevant to hemostasis and transfusion. For patients who receive transfusions postoperatively, which will be defined as any transfusion started after the patient had left the operating room, similar data will be collected. The primary outcome will be the incidence of post-op complications known to be associated with transfusion, including the development of any infection, clinical evidence of end organ dysfunction, the development of respiratory complications including the duration and modality of mechanical ventilation, the length of the patient's ICU stay and overall hospitalization, evidence of hemodynamic instability and support, and mortality. Secondary outcomes include the frequency and characteristics of intraoperative and postoperative transfusion requirements, and the association between the age of transfused blood products and the incidence of post-op complications. Data will be analyzed to assess for relationships between the pre, intra, and postoperative variables and patient outcomes. A logistic regression analysis will be used to evaluate the association of post-op complications with blood product transfusion. This allows the data to be corrected for any preoperative and intraoperative variables. Potential limitations of our study include its retrospective design, the fact that it's a single-center study, the variability in post-op transfusion practices among providers, and the variability in surgical technique. Although these are limitations, this study is important to advance our knowledge about blood transfusion practices and to improve the quality of care we provide. Anytime a review of the medical record is conducted, there is always a risk of patient data being discovered and the loss of confidentiality. This risk will be mitigated by conducting all study procedures in accordance with IRB and HIPAA requirements, by assigning study numbers to qualifying patients in place of identifiers, and by securing the code linking the study numbers to patient identifiers in a password-protected file. Overall, the risk of privacy being compromised is extremely small. Finally, the anticipated outcomes of this study are the determination of an optimal transfusion strategy for pediatric patients undergoing cardiac surgery with cardiopulmonary bypass, improvement in the quality of care provided by our institution, and reduction of transfusion-associated morbidity, ultimately leading to better outcomes for these patients. Thank you very much for your attention and for considering my research on how to improve transfusion practices and ultimately improve the quality of care for our patients undergoing cardiopulmonary bypass.